My name is Sumit Sajnani. I serve as the state of Connecticut's Health Information Technology Officer based out of the Office of Health Strategy, and it's good to be here with you. Office of Health Strategy is uniquely positioned in Connecticut, which is very different than some of the other states where we are not a service provider agency. We work with a variety of stakeholders that obviously includes patients, patient advocates, payers, providers, understand where their challenges are and put forward policies, investments, statutory recommendations on how the state government can help on three key areas. It deals with equity, it deals with better health outcomes, and it deals with unit costs and total cost of healthcare, which is a critical component. And because we are at HIMSS and it's a technology forum, I think technology can play a critical role in helping with all three of these areas. So as the Health Information Technology Officer, I get a broad statewide view of these challenges. We've put forward a 5-year health IT plan, which does a variety of things working with providers, payers, community-based organizations, the human and health services agencies across the state, working with the national government on a variety of standards. So it's a pretty broad portfolio. I also oversee the state's APCD, which is the All-Payer Claims Database, and administer the state's Health Information Exchange, which uniquely in Connecticut is mandated to have every provider, every licensed healthcare provider in Connecticut connecting with the statewide Health Information Exchange and providing patients access to their complete medical record at no charge to them. So this is a free service provided to all residents of Connecticut. So pretty exciting, broad portfolio, and happy to talk to you about anything within that. Health equity has been something that's been at the forefront for the last few years. Office of Health Strategy and Connecticut has taken health equity extremely seriously. Health equity to me means you have access to good quality care and you can reach the maximum best potential of your health outcome. What that means from a technology perspective first is making sure that when we provide coverage, everything begins with coverage. Connecticut has come up with a program called Covered Connecticut, which if you are in the bracket of income that doesn't qualify for Medicaid and you have to go to the insurance exchange to purchase your coverage, you're able to have your out-of-pocket expenses covered by the state of Connecticut. This is very critical because a lot of people that fall in that donut hole of they don't have full commercial coverage through their employer, yet they have low enough income but not low that they would qualify for Medicaid, they're able to get coverage. So equity first begins with having coverage. The second thing is access. We are working with community-based organizations. We're working on connecting the data between referrals and community-based organizations to allow for access to referrals for continuity of care so that patients who are finished with clinical settings are then able to, outside the hospital setting, get additional care. The third thing is recognizing data such as race, ethnicity, and language, collecting that data at a granular level. We've put forward a mandate, and this is a statewide mandate that every provider organization in Connecticut needs to follow. You are required to ask every patient and every state agency that has clients what their race, ethnicity, and language is. This is optional for the individual to provide, but mandated for the agencies and provider organizations to ask. What this data allows provider organizations and agencies to do is develop interventions that are specific to their community needs. And what we've done with the granular race, ethnicity, and language is allow for people to be represented the way they see themselves instead of being seen as check marks on a summary sheet. It also allows for biracial, multiracial individuals to select multiple boxes. So these are critical things that we're doing from an equity perspective. Equity is not a destination. We've been working on this for some time. This is a journey. It will continue to happen. And as more and more data and more community engagement happens and the trust develops between the community, the providers, the government, and other stakeholders, we're going to see the impact of that and the change that it brings to the entire ecosystem. Absolutely. So obviously because we're at HIMSS, for the last 2 years, the big topic has been AI. But when we talk about AI, the underlying requirement is to have good data, high quality data, and high volume of data. So data interoperability continues to be a critical aspect on all things such as access, unit costs, overall healthcare cost, and making sure that we're getting better outcomes. I also would say that I think we've reached a point where health data no longer is limited to clinical data. So 70% of health outcomes are actually driven by things that happen outside of clinical settings. So if you're talking about social determinants of health, that is driving a significant portion of where people's health is. I was talking to an FQHC in Connecticut recently, and they told me that 6 out of 10 cardiac referrals were going unfulfilled in their community for a variety of reasons not associated with coverage, whether it be that you can't take a day off to go get those services, or you can't take care of your children or get child care for you to go get those services. What data interoperability allows us to do is look at what those social determinants of health are, so we can start looking at those assessments, make investments as the state in those appropriate interventions, work with community-based organizations. So whether we're talking about housing insecurity or food insecurity, having the data available to know where the demands are and then making the appropriate investments to counter those demands is critical, and the data interoperability allows us to do that. We're also looking at state agency data. So we've noticed that a number of clients have associations with multiple state agencies on different programs. You could be working with Department of Social Services on the Medicaid program and working with Department of Housing on some voucher. Having a 360-degree view of a client across state agencies with appropriate privacy and consent, and having that data interoperability is critical. I think we've also seen on the EHR front a lot of enhancements on the CDI new version that's come out, and what the federal government's going to be requiring EHR systems to do as of 2026 is to have that expanded CDI version, which is going to include social determinants of health. So I think we need similar types of standardized data across clinical settings, outside of clinical settings, and being able to see trend analysis, pair data, clinical data working together to look at what those interventions need to be and how the state and technology, people and processes can play a role together to improve overall health outcomes. Yeah, this is a great question. I think there are a number of things that are changing in terms of services. So over the last couple years, you've probably heard people talk about no wrong door or one single door for state services. What Connecticut has done in terms of online is create a portal where every single resident of Connecticut is able to go in and access every possible state service, whether you want to renew your driver's license, or you want to get your fishing license, or you want to apply for SNAP benefits, whether you want to look at some items related to your taxes. Having a single sign-on, a single profile, allows residents to not have to chase services at different points. They're able to get one single door. And that's not to say if you're one of those residents that is not digitally savvy, that that's the only way for you to get services. We've also created, and the governor has just announced this year, that we're going to have something called opportunity centers. And this ties back to data integration and technology working at the speed that individuals need services across agencies. What these opportunity centers are going to be doing is allowing residents to walk into a mobile center or a local community center and ask for services across multiple agencies. Obviously, this is going to start out as a pilot. We're going to begin with certain services and then expand on them as time goes on. But what this allows people to do is, instead of going to different agencies for different issues, whether it is because you're applying for unemployment benefits or you're looking for other services, you're able to go into a single opportunity center to have all of your state-related services handled in one transaction, in one time. So it cuts down on the time that it takes, it cuts down on the burden that individuals need to go through. So it's really important that these services are expanded. And all of this ties back to equity, to underserved communities. So you can see that all of these things are themes that go together. Data interoperability ties into serving greater communities, getting people greater access, responding to demands that might exist and show up in trends. So all of the data and the AI sitting on top of it needs to work together.